Okay, Alita, did you want to share our slides? So welcome everyone. We're going to get started. Thank you so much, Alita. So I wanted to welcome everyone, and I'm going to start with our acknowledgement. So the head office of the Mental Health Commission of Canada is located on the unceded traditional territory of the Algonquin Anishinaabe Nation. It is now called Ottawa, Ontario. We acknowledge that for thousands of years, the Algonquin people protected these lands, the Ottawa River, Rivershed, and its tributaries. As a national organization, we also acknowledge that we work on the traditional lands of many different nations. Today, a path to truth and reconciliation begins with the recognition both of the stewardship and the sacrifices of the original peoples. We're committed to recognizing the errors of the past, acknowledging the challenges of the present, and contributing to a new and respectful relationship with First Peoples. I'd like to invite you all to introduce yourself in the chat and to provide your territory acknowledgements in the chat. You should have access to the chat during the whole webinar. We are recording this session and we plan to share it with those in attendance. The host has muted all participants to optimize sound, so please use the chat for the moment, but know that when it's time for the facilitated discussion session and for the presentations, you'll be able to speak and you'll be able to raise your hand or put your question directly in the chat. Carrie and Alita will be monitoring the chat. So for any technical questions, you can send a message directly to Alita Igubir. So her information will be available in the chat if you'd like to if you need to send an email message with any technical questions. She's also the one sharing her screen, so thank you very much for that. And I'd also like to thank Carrie Richards, our wonderful program coordinator, for coordinating and putting together this whole webinar. So thank you so much, Carrie. And I will also be co-presenting with Anne-Marie Churchill and Alexia Jowich. So I'll just be providing a little bit more information before I start things off. So we're hosting our Stepped Care 2.0 webinar today. MHCC is really proud to champion Stepped Care 2.0 as part of our mandate to improve access to quality care. And for us, this means stigma-free, informed, safe, inclusive, seamless, person-centered care. So we're going to continue conversations on what this means and what this looks like. And we will be here to continue to support provinces and territories and organizations in this work, as well to support resource development and knowledge exchange, like this webinar, for example. So we really, really enjoy bringing folks together, and that's the main reason that we're here today. So I'll go to the next slide, Alita. And thank you all those for putting your acknowledgements in the chat. So another warm welcome. The purpose today is really for information sharing and knowledge sharing around Stepped Care 2.0 work, and really all of your work, fabulous work that you do to improve access to quality care. We're going to have a discussion on the benefits and successes and also what we've learned in our journeys. The outcome is an opportunity to share those benefits and successes and really things that you've learned that are working well or that need to be improved. And it's really for the goal to inform and support all of our work. So this is going to be a 2.5-hour virtual meeting. The first hour or so is really for an update on the work, hearing from others that are doing this work, and then we're going to have a really hearty discussion period. So we have a facilitated Q&A with the panelists, but we really are encouraging everyone attending to discuss, ask your questions, and then we'll end with a post-webinar survey for continuous improvement. So I'll go to the next slide, give a bit of an overview on our agenda. We started with the welcome, and then next we're going to go into a summary of the work so far and some of the lessons that we've learned. So we've been gathering, over the last few years, we've been gathering really valuable lessons and some things that are working well and some things that could still be improved. So we wanted to give a summary of that work before we open it up for presentations and discussions. And then we'll have the presentations from provinces and territories and organization with people with lived expertise. So we're really looking forward to hearing directly from you, from the community that is contributing to this work and supporting this work. We're going to have a quick health break, but at any point, feel free to, take care of things, take a health break, come back as you need to. You can come and go in this meeting as needed. And we'll also be circulating the recording. And then we'll end with a facilitated discussion Q&A period. So we know that folks have really enjoyed and really benefited from asking questions, being able to discuss different topics together. So we're hoping for a really good discussion today. And before I hand it over to Anne-Marie and Alexia, really who best to speak to Stepped Care 2.0 and the system transformation. As you all know, this is a transformative model for the organization and delivery of mental health and substance use health services. It's really focused on wellness. So I'm so happy to be championing this approach and to be hosting this webinar today. And I will hand it over to Anne-Marie and Alexia.
Great. Thanks so much, Daniel. It's great to see everybody here. It's wonderful to be here. I'm just coming off COVID, and I think so is Alexia, which is pretty funny. We're not it's not funny, we have COVID, but it's interesting that we're virtual. We're not seeing each other, and yet a number of us on our team have COVID. It seems to be spreading through our computers or something. Okay, so do we want to jump right in, Danielle, with our what is Stepped Care 2.0? So I wanted to start with saying, first of all, it's great to be here. I see a lot of people on the screen I haven't seen for a while. So thank you so much for joining. I realize some people here have a lot of experience with Stepped Care 2.0, and we're going to hear about that today. And I'm continually learning from places that are implementing this model. However, others are new to the conversation. So what we plan to do is do a quick overview. And I really want you to know that MHCC and Stepped Care Solutions have a lot of informational resources, and we love to discuss anything and all things Stepped Care 2.0. So please, if you hear something or you want to do a deeper dive into something we're talking about here today, feel free to reach out to either one of us. You'll have our contact information at the end on the slideshow today, and you can reach out to us at any time. So what's Stepped Care 2.0? To summarize, it's really a system level model for integrating. I think integration is very, very important, organizing and delivering mental health and substance use health and addiction services. So it's really trying to work with communities, all stakeholders, in taking all of these services that are in our ecosystem and bringing them together in an integrated way that organizes them and delivers them in a way that really increases access. So the model is built on a set of principles for system transformation. And these principles, there's a number of them, but they're related to things you heard Danielle just mention, access. So they're related to ensuring resources and supports are available when people need them. So care at the point of need when people first reach out, that there's informed choice, for example, so people know what to expect from various services and what's expected of them to engage with the service to get the positive outcomes or the expected outcomes. Another really important principle are things like multiple options that range across a level of intensities to meet diverse needs and preferences. Another really important aspect of the principles is that systems are culturally responsive, so that services align with people's unique perspectives and their way of being for health and wellness. And another really important piece is this idea of routine data collection. So we've been working a lot on thinking about measurement-based care in the context of mental health and substance use health and addiction service delivery. And so there's routine data collected across all levels of the system. And then first and foremost, for the people using the services, and then care providers to monitor for effectiveness and adapt. And then, of course, for the system level, for continuous improvement, which is extremely important. It needs to be a living system that garners feedback, and gleaned from that are areas for improvement. So those are just sort of an overview of the principles. As I mentioned, there's a number of principles. And what these principles do is really facilitate the implementation of stepped care, but we also need core components. So core components are the piece that really address practice-based applications. So although principles tend to be high level, core components provide this operational aspects that line up with the principles, supporting system change and development. And then the third piece, which we find really important, is the planning framework. So planning frameworks really help jurisdictions, organizations, communities to be able to identify their current resources, but also identify gaps. And so then that really helps with system improvement and in integrating and tying all of these pieces together. Next slide, please. We included this slide because we're often being asked about how is Stepped Care 2.0 different from other stepped care models. And stepped care, the idea of stepped care, has really garnered a lot of attention, and there are some differences in the different models. Of course, Stepped Care 2.0 was based on the UK model, and then we adapted it to really fit our ideas and our principles around mental health, substance use, health, addiction service delivery. A common one is stratified models. And of course, many of us have worked in this type of system where it's really based on a matching of symptom level or severity with intensity level of a service. So for instance, if people have low symptom severity, then they may be prescribed or directed or recommended a low intensity service. So it's generally low severity, low intensity, high severity, high intensity. A progressive model is a bit different in that the idea is everybody starts at the least intensive and only moves into higher intensity services as it's deemed necessary, either through ongoing progress monitoring with symptom checks or with progress. So if people aren't making progress in one level, then they would be recommended a higher level of service. And then the Stepped Care 2.0 model, it's not that none of that happens, is that that's not the priority. The priority is really to get at a person's level of readiness, ready to engage with the service, readiness for the type of service, and then their preference level as well. So what kind or what type of service modality do you prefer? And that really goes back to and ties into the principle of informed choice. So for people to be able to make those choices in a Stepped Care 2.0 model, they have to be provided the information on the services, but also the routine monitoring to see how they're doing and to be able to shift to different levels of care as needed. So the Stepped Care 2.0 model is really based on choice and preference, informed choice, and level of autonomy. Some people want to do things on their own. We hear this a lot. Even with a high severity or complex case, they want to try some things on their own, or they want some lower levels of care. And so being able to do that, having that lower level of autonomy type service, even though maybe there's higher levels of care required, they could be doing both. So someone could be engaged with a higher level of care and using a lower intensity service. So that kind of mix, that kind of tailoring, really client-centered or person-centered care is what Stepped Care 2.0 is really trying to provide for people as a regular type of care. So I'll stop there, and Alexia is going to do the next slide.
Hi, everyone. Nice to see you. And I'm just going to build off a little bit from what Anne-Marie was saying. And this is something that we've been thinking about over the last 3 years or so as we were putting some of these ideas together. Okay, what have we learned about our work, and yes, in the provinces and other jurisdictions as well, and organizations, and what are we still seeing as a bit unique, and where, and then the next slide I'm going to share is where are people still kind of really those tough things that are there to changing our system and our services. So I want to just talk a little bit about that. We want to do a bit of reflection as well in terms of our learnings. And I think part of what we've continued to build and kind of share with folks that we really see Step Care 2.0 as a population approach. And we're seeing that as something that looks a little bit different in some of our implementations of really looking across all of these services, both formal and informal. How can we meet the needs of the whole population? Those who may identify of having certain mental health challenges or issues or concerns they want to discuss, and how about our general population? So we can think about health promotion, prevention, early intervention, the whole spectrum. So part of that is that some of what we're seeing in terms of those kind of key features for the Step Care model, the 2.0 model. Another piece that we're seeing as unique, and that's connected to what Emery was just sharing, is this idea of the care options being in the hands of the people who are really accessing services. And you'll see that in the next slide, I'll talk a little bit about that. Still seems to be really a shift for folks to think that through. What would that mean? What does that look like? And really having the decisions being based on the person's preference, readiness, and ability to invest. Doesn't mean that symptoms and functionings aren't part of that conversation, but really kind of weighing some of those factors more heavily towards the choice for the individual person. And looking at how do we promote our systems to be really restorative and proactive, and looking at any interaction that we have, any part of our system building and service building as part of this restorative approach that can really meet some of the goals around social justice and equity, around folks having access to services that meet their needs, and the types of services in the way that best meet their individual needs. And therefore requires in the next step here, the next piece, this kind of idea of co-design. So if we're going to aim for a more equitable system that meets the needs of a diverse population, really needing to look at co-designing the services, but also the system in and of itself, so that they are relevant to each unique niche of the communities. And I always say this at any beginning of an implementation, is that whether we're at your university, a youth hub, a community mental health agency, or province, really every implementation looks different, because we are co-designing and looking at the needs of that particular community and population. It will necessarily look different in its implementation. But what we're always looking at is that the principles are there. They're the underlying work that we're all, underlying kind of foundation for what we're all trying to accomplish together. And then the next piece here that we still find as being a bit of a unique feature is this idea of the minimal upfront assessments. So again, talk a little bit about that in the next slide. That really is something that seems to be a substantial shift in system and services, to think through a bit differently how assessment takes place, when, for who, as a default for everyone, or as at certain points in time in that process of discussion with an individual person. And using data mostly for the use of the person accessing services to be able to track their wellness, track their services, and make really informed decisions about their own care. And of course, where appropriate, using that information to discuss with their provider across the full continuum of services. So how do we use data and help inform people's journeys across all of those steps? Right now it's often used at our step 7, individual therapy. How do we broaden that even further to really create that kind of person-centric and strength-based orientation to our systems, where every interaction, and this is what we mean by an OAT approach, a one-at-a-time approach. We know that lots of implementations often implement one-at-a-time therapy, and that's really helpful because people get that first point of contact, can get an interaction, a therapy session in that moment, a counseling session when they're most reaching out for that need. But how do we also have that idea of each interaction in all steps can be really therapeutic and helpful, and be self-contained as something that the person can really benefit from in their journey, their wellness journey. So we still see these kinds of these features as being the unique pieces. There are others, but when Emery and I were reflecting, we really see these as coming up over and over again as to what makes 2.0 distinctive. And you'll see in the next slide, if you can move to the next slide, the kind of corollary learnings that we have around the implementation learning. So if we can move to the next slide. So you'll see here, there's a parallel from what the slide that you just saw to here. But these are, again, some of the things that we see as still, when we're working in different settings, different populations, the kind of tough nuts to crack, the tough things to change in our system, because of the way it was built, because of the way we're all trained and just been used to providing services. But really the idea of pretty much any implementation, thinking about how to change the access process, how people to make access just that much easier, so that when people reach out at that point of readiness, at that point of need, they can get a service at that point in time. That often means reducing our kind of administrative, but also assessment processes to make that much easier. And thinking through, again, where does the assessment, where does that continuous information get collected, and when is a full biopsychosocial assessment key and needed, and that now being the default at the first point of care is still a substantial kind of change for people in redesigning their systems, whether they're small, medium, or large across a whole province. We find that also kind of in this approach, the principles appeal to people, being strength-based, being person-centric. But sometimes what was seen is when people were working through those ideas, how do we move away from our reliance on our own clinical expertise? Not that our clinical expertise isn't part of the discussion. Of course it is, and it's everyone's, we always say using clinical judgment. How do we shift that as well as those first interactions? How do we rely more heavily on what the person's bringing to the table and think about how to incorporate our clinical expertise as we go? In terms of the co-design, to mirror a little bit our unique features from the last slide, it is still really challenging to co-design our systems and services, sharing in that power and leaving it really open. There's still often anxiety around leaving that discussion open around what are we trying to design in terms of access, smoother access. What would that look like? And really leaving that open for conversation and hearing from lots of different voices around what would be beneficial. I use the access point as a discussion, but there's lots of places that can be co-designed. But what we're finding is that it is still difficult and takes really thoughtful processes to co-design well, because it does mean being open to entirely different ways of doing things. And that can be difficult when we know there are real pressures on our system to get things going quickly. So time and co-design don't always go together. And not assuming that people need long-term therapy and that more care is better. It is part of how we've all been socialized in our system, that the gold standard is individual therapy, and our system is designed for some of those higher levels of care. And so again, what our experience has been is that when we talk about the principles, people really feel like, whether it's a small, medium, large organization, a whole province, that these make a lot of sense. But sometimes, challenging our own assumptions and the assumptions of all folks in the system about long-term therapy, the gold standard, still requires a fair bit of discussion and unpacking and unlayering what that means and how we came to those assumptions in our system. And last piece is here, just concerned, aware of time, is still being able to see the full continuum. From 1 to 9, it's tied to this last piece around being a siloed approach. Our systems are siloed. We see our part of the pie. Now, lots of folks, like some of you in the room who are sitting at that governmental, at that kind of provincial perspective, sometimes see the whole picture. But for any individual provider, seeing the whole picture of what exists in a system is both challenging, because there's a lot in our system, both formal and informal. And also, we're really busy. Every provider is really busy doing their best they can to provide their service. So how do we build in some time and some knowledge to seeing and building a full service, and that incorporates those informal services? So something that's always really neat when we do an activity called Populating the Model, and we explore what exists in our system along those 9 steps with people who've used this system, a lot of what gets brought up are the more informal services, the community services, the cultural supports, traditional supports, the Y down the street, all of these kind of things that exist naturally in our systems that don't always get incorporated in what we think of our mental health and addiction system. So if we open that up, we can really see abundance versus ability, this kind of scarcity model of, yes, when we think of formal mental health services and substance use services, addiction services, definitely more resources are needed in our system. But if we also open that up to everything that exists in our system, how can we see the abundance that can exist if we leverage the full continuum and the full workforce who can provide supports? We can all provide some supports in this full continuum. So we're still seeing these aspects as part of are pretty common conversations with most jurisdictions, organizations. So they still seem to be the thing that we really need to focus on to help people shift their paradigm around what is really possible here in our systems. I think I'll turn it over to you, Danielle, for the next slide.
Thank you, Alexia and Anne-Marie. I think that's always really well said about what you're hearing, the experience, and what can we move forward. So I'll be sharing really what we've learned from all of you and all of our partners. These are some themes or some learnings that we've heard many times throughout our work and our partnerships. They've come up at our national Steps Care 2.0 collaborative meetings. They've come up in our work with provinces and territories and organizations and different working groups and advisory groups that help us do the work, and then they're doing the work and leading the work themselves. So these are some of the recommendations from our final reports as well. So you can dive into those final reports on the MHCC website, but we thought that we would collect these all and then summarize these all the best we can. So some of the main themes that we've been hearing from folks is how important it is for early and ongoing engagement, communication, and partnership. So especially when you are really looking at implementing an integrated full continuum of care, as was just spoken about, it's really important that you engage. It's really important that you involve people in the work, that you communicate about the work, that you receive feedback about what could be improved and brainstorm different ideas and get a lot of diverse, different opinions and perspectives, that you use a variety of different methods so people learn and want to give feedback in different ways. So it's really important that you have like a multi-pronged approach to your engagement and that you continue to engage and communicate. We've had really good examples of some communication. For example, Northwest Territories released a communications postcard that has been really well received and explains the model. And then we're working to develop one with Health PEI. So just to give some examples of some types of communication that you can be doing with any time you're trying to improve access to quality care. It's also so important to build those relationships with the community. So Alexia was mentioning about, really tapping into the full continuum of care. And to do that, you need to build and strengthen those relationships. So what is going on with the community? What's going on with each different service or department? Like health or education, to really gain those diverse perspectives about what's actually happening, what's available in the system, and where do we need to build trust and awareness and interest to really get buy-in and co-develop this continuum of care. The next is co-design for a shared vision and goals, and co-develop a meaningful approach and celebrate success. So it's so important that when you're doing this engagement and communication, that you really co-develop this shared vision and goals. When everyone is on board and co-develops the vision and goals, it's so much easier to then work together to develop a good, meaningful approach and a good, meaningful plan that everyone can do their part in and can contribute to. And it's so important to celebrate successes. So celebrate early wins, small wins, and continue to really check in and celebrate those successes. Share what's going well from one community or one department to the other. It's just so important. Always relate it back to your original goals. And check in on those goals with each other. So that's really important, especially when doing system transformation, like Stepped Care 2.0, to really continue to check in on your goals. And next, early and ongoing leadership, support, resources, and training. So there is a lot here. This is really a really important one, is that you need early and ongoing leadership. So leadership can look like a lot of different things, and you don't need to be in a leadership position to provide leadership. We know a lot of champions that are, really moving things forward and providing that leadership. But it's so important to have strong leadership that can keep things going and make things sustainable. You need support, so you need human resource support. That's so critical to be able to provide that support. And also even just that one-on-one personal support. We know during system transformation and change management, is not always easy. It does take time, resources, and support. Sometimes you will need, technology support or infrastructure support, definitely some training support. So Stepped Care Solutions provide some wonderful training. You also have training within your organizations that are so vital to be able to realize your goals, and really have the training and supports tied back to your goals and to your overall vision for success. So this is really important. It's important to really build this into your onboarding and to the culture, and really reflect back the principles, including the principles of the model, to really make sure that this is embedded in your culture, and it really is the way that you can keep this going. Some things like revising policies or processes, like intake procedures, that's been done really successfully by some provinces and territories and some organizations, and just looking for ways that you can continuously adjust and improve to make sure that, recovery and strength-based principles, like person-centered care, co-design, shared decision-making, choices are really prioritized within the resources and the training provided. And then finally, we have plan for continuous improvement and long-term sustainability. So you heard that continuous improvement is one of the core components and core principles. So just really making sure that you're thinking about ways to incorporate that continuous improvement. So, doing check-ins during your meetings, having frequent check-ins where you're looking at the data, you're looking at the evidence, you're looking at the feedback that you're receiving from everyone involved, and really making meaningful choices and actions for how to improve. Also, are you looking to improve or are you looking to expand? This can really depend on your original goal. And it's important to have, as we mentioned in step 2, about having a meaningful, phased approach to care, to this implementation. So as Anne-Marie mentioned, we do have a lot of resources to support this kind of continuous improvement and long-term sustainability. So please reach out. But we're also hoping the discussion today will help with some core themes or issues that people are looking to discuss and have some support for. So I will pass it back to Anne-Marie with that to end our part of the presentation.
Thanks, Danielle. That was really helpful. And so before we dive into the next section, I just wanted to say, I find this slide is important. I think about this and what we're doing here today as a type of systems approach. So just like one intervention or one service won't be a fit for everyone or one person at all times of their lives, that Stepped Care 2.0 isn't a set model that everybody implements the same. And what you're going to hear, and why I love these collaboratives, is you'll hear from different jurisdictions how they've actually taken those principles looked at some of the core components and have transformed, revised, developed their own mental health, substance use, health, and addiction services. And I think that's what's fascinating is when we put the principles out there, most people go, yes. And it's not always easy. And Alexia outlined some of the challenges that we work through, both for ourselves and with people we work with and organizations we work with. And that's whether it's provinces or states or community mental health centers or post-secondary institutions. It does, the model itself and the way it's implemented or how it looks or the planning framework looks different in different places. But what people are trying to get to are the principles that really should promote open access and better outcomes. And that's the key. So how do we get there? And when we come together like this, we actually get to hear from each other how we're making it through using the principles or focusing, or that's the North Star, or using different approaches to get there. And I think there's so much for us to learn from each other. And every time there's a different implementation or we watch some system transformation, we learn how we can do it differently. And Danielle mentioned like the postcards in Northwest Territories, or the ability to shift from long biopsychosocials at the first point of contact to something more helpful, useful to the person accessing services. So those types of ideas and others who've implemented e-mental health in a really big way, what's happening is we're learning how to do that and how to do it in a way that maybe we can tailor to get to the ultimate outcome, which is really that improved access and improved outcomes. So I'm just, again, great to be here. I'm really interested in hearing each person's report and then the discussion, because it's often in the discussion that we work out some of these ideas and address some of our own challenges. So I'm looking forward to that. Thanks, Danielle.
Yeah, thank you. So we will pass it on for the next session. So I'm really happy that some of our key members, our key partners will be presenting today. So as we've mentioned, this is really a flexible approach. Each organization, is adapting it to fit their own needs and goals and their own system. So we want to hear directly from them. So Alita, I'll get you to go to the next slide, please. So we'll hear directly from them on successes and learnings. We'll hear from a few provinces and territories and organizations with lived experience. And up next, so I'll get you to go to the next slide. So up first, we have Newfoundland and Labrador and LifeWise. So really pleased that we've put you first, Byron and Brad. I hope you don't mind. Because you really started this partnership with us, this journey with us as the demonstration project. So we were first demonstrating this model in a province-wide approach. So without further ado, I'll hand it over to you both.
Thanks very much, Danielle. And we're okay with going first. You may regret it because me and Brad could probably take up the next 5 hours, let alone 5 minutes on this topic, but I will try my best to clue up my couple of slides quickly so Brad can finish it up. So if you can move to the next slide. So we're just going to share, as was outlined to us, kind of what the focus of the conversation was today. So when we look at our benefits and successes here in Newfoundland, one of the biggest things was easier system navigation because of the 3 access points. And the addition of 811 as an access point for individuals to access mental health and addiction services here in Newfoundland and Labrador was huge, and really gives an opportunity for individuals to have an ease of use. 811 also functions as our mental health crisis line. So oftentimes individuals will call in a crisis, have their crisis kind of dealt with in that moment, and then be able to have a referral to services initiated all in the same call. And it really makes for ease of use for the end user. And that's really what this is all about, is, ensuring that our clients, the people, the end users of the service have the best possible experience. So 811 is our telephone, doorways is our in-person, Bridge the Gap as our online option is not fully developed yet. It is online option in terms of it explains all the services available and what's out there. We haven't integrated an actual referral process into that because it's a little bit more complicated in our province with our legislation and how we handle the personal health information on the back end of that. But we are hoping to have that fully established in the next 12 to 18 months as we work through our health system integration that we just went through and ironing out some of those pieces. The second piece of the benefit and success is a clear model with robust service offerings. And when we look at our model and how it's going to arrange, we know it looks a little bit different than what a lot of models do, but the core principles and concepts are still there. And really, in the province of Newfoundland and Labrador, there was a clear investment in resources in all steps along the way to ensure that we had better access to services for the end user. And one of the biggest things that we looked at, and one of the biggest successes that came out of the pilot project here in Newfoundland and Labrador, was more timely access to care. So trying to reduce wait lists, trying to provide more access. And, there's a slew of people on this call who are involved in our implementation and the pilot project and can talk about, how big of a difference it is in terms of service utilization in Newfoundland and Labrador when we talk about doorways and having that one at a time single session model and the access that gives to our individuals here in the province. There's also a commitment to recovery principles and integrating strengths-based assessments at all levels and having, we just started our pilot project of measurement-based care using the Green Space platform here in the province. And that's going really well. And we really hope that will be a continued tool that we'll have access to and really provides a really different feel for services for individuals. And the last piece here is the incorporation of lived and living expertise at every phase. And here in Newfoundland and Labrador, we have the amazing opportunity to partner with LifeWise as our organization for individuals' lived experience. And we've just enjoyed an amazing partnership with them at every step along this continuum as we've been building out our step care model and adapting our services to better meet the end needs, the needs of our end user. Next slide. When we talk about the impact on work for individuals who work within that system, we look at the greater collaboration and engagement among internal and external stakeholders. And we do have a really good partnerships and engagement with various organizations that work in our communities in Newfoundland and Labrador. Improved navigation for both clinicians and individuals using services. And I know that feels a little bit maybe counterintuitive to say it that way, but there were a lot of clinicians working in our system who were so siloed that they really did not have a good understanding of what other services were available to individuals. And through our step care process and the trainings that people went through, a lot of our clinicians would express that they now have a better handle on what is available to people and are more comfortable having that conversation to say, hey, Byron, you've seen me for X number of sessions. Are you aware that this service exists, that service exists, and maybe there are other options that'll better meet your needs at this point? So people are far more comfortable having that conversation. And obviously individuals who are using the service experience better navigation because things are laid out better, things are more intuitive in terms of what your options are and what's available to you. And through that process, and I know here where I work in our central zone in Newfoundland, the concept of services being more person focused, and we've had a really intentional shift here in the last couple 3-4 years to really that person and family centered care approach that we need to include individuals and key members of their support networks in their decision making process and to be involved in kind of every step of that process. Next slide. Last slide from me, and I'm going to pass it off to Brad. Hopefully I didn't took too much time. Top 3 lessons that we learned. The importance of leadership buy-in. And when we look at a lot of the work that's been done here in Newfoundland and Labrador, a lot of it came from our Towards Recovery kind of all-party committee that happened here in the province. And having that buy-in from all the political parties and not having to worry that if there was an election, there was going to be a stick of dynamite put in the middle of all the work was a really big win for us in terms of how that looked. When we talk about the importance of capacity building, there was a lot of financial resources and program resources. We look at, e-mental health, there's significant investments. When we look at FACT teams being established and additional staff, There was capacity added to the system for doorways in terms of dedicated resources. So there's a big piece to that. And then the last piece is important of communication. So need to have ongoing communication, both internal and external, about the model and services within. And we'll talk a little bit more about communication further down in the presentation as Brad takes over. So take it away, Mr. Glenn.
Thanks, Byron. Hey, everyone. I'll be relatively quick with this one. This is my favorite one, communication. Last week, I got to say this to our minister and to the leadership team of our health authority. We need to become comfortable with marketing and communicating in mental health services. If I break my arm, I know I need to go to the hospital. The same isn't always true for mental illness, for substance use issues, for addiction issues. And we need a strategic plan towards that. The biggest thing is we need to get comfortable putting financial resources to supporting that in all the ways, both for people working within the system, population health basis, and people, possibly living with severe persistent mental illness and different groups of people. Because a resource can be a Cadillac, but if people don't realize it's there, it's a Cadillac in a garage not being used. Political will be hard to get behind that because it's not popular, and operationally, I don't think it'll be super popular in most health authorities. And I really think people with lived experience, like our organization, play a huge role in backing the larger systems in saying we support that. We put a huge amount of revenue into marketing, communications, and LifeWise, and do it unapologetically because it needs to be there. And it needs to be consistent from beginning, middle to the end. And I want to give Newfoundland and Labrador credit because they're working to do that. And I think they see that need. And, utilizing larger organizations and organizations with different footprints like the Commission are part of that. But I think we've got to become a little bit less modest and less apologetic about the fact people need to know our services are out there. And next slide. And then, the advice, LifeWise is obviously going to say involve lived expertise. I'll always add the caveat of ensuring that it's not just people with privilege with lived expertise. Myself and Sarah are here, but we're, in places in our wellness that we're good enough to be doing our day jobs without much hassle. We're able to kind of be engaging in society, but, ensuring that we're inviting marginal and vulnerable populations, particularly, members of racialized community, Indigenous folks, members of the 2S LGBT community who are often marginalized in different ways, people with precarious housing, substance use, all those issues that are a little less comfortable, ensuring those folks are actually at the table. I just spoke about dedicating resource, so that one isn't there, and the strong communications plan. And then the last slide is, the tagline that really the government has used here with their step care model is the right care at the right time. And remember that that's what we want to do, right? We can meet everyone's needs from low level needs to high level needs if we improve mental health literacy and improve our ability to have people access what they should receive. And the reminder that it's the individual receiving care who determines what the right care is and what the right time is for it. So that's it for me. I'm going to Danielle or Carrie. I'm not sure who I'm passing it back to right now, but I'll pass it back.
Yeah, thank you. So well said. Yeah, so important to have the right care at the right time as decided by that person receiving the care. So yeah, thank you so much both. That was really great. I think that was really helpful for folks. So I'm going to pass it on to our next presenters from New Brunswick. We have Deborah and Stefan. So Deborah and Stefan, I will pass it over to you.
I wonder if it would be easier for me to share my screen or maybe we keep it that way. I don't know. Just for slides.
We have them open. If you can guide Alita for the next slide, okay. if that works.
No problem. Excuse me. So my name is Deborah Cyr-Lebel, Director of Adult Services within the Department of Health in New Brunswick. And for us, we're just starting to implement step care. We can maybe move to the next slide. So the vision for New Brunswick, the key things we're trying to accomplish, the number one thing is rapid access to addictions and mental health services. The other one is integrated system of formal and informal addictions and mental health supports, reducing wait time for longer term or higher intensity services, excuse me, and also a shared approach in empowering clients to make informed choices. So those are our 4 things that we really want to accomplish moving forward. Next step, please. So phase one, we started our journey by implementing one-at-a-time therapy, which most of you probably know what it is all about. So one-at-a-time therapy plays an integral role in step care, as it is a low barrier, rapid access point of entry to services that provide early intervention as well as guided navigation towards more specialized or longer term services when needed. So for us in New Brunswick, we started this journey and we were successful in implementing one-at-a-time therapy for adult services in October 2021. And then we moved towards child and youth, and we're able to implement one-at-a-time therapy for that population as well in 2022. So early results are really, really interesting and positive. Maybe next slide, please. So again, you know, the good news is that, you know, with one-at-a-time therapy, there's no exclusion criteria. Everybody's welcome to come, which is, you know, transforming our system basically. It's not limited to in-person only, so we offer it virtual, telephone, whatever the client may need, we adjust services to them. There's no wait list for this service. There's no professional referrals needed, and there's no lengthy intake assessments. We've removed that to really improve access to services. All are welcome. Again, it's people can just walk in for services as well. So it reduced, and all of this was implemented during COVID. And the RHAs were really pleased about that because it kind of saved them. They would not have, and this is what they're telling us, is that they would not have been able to survive or, you know, maintain services during COVID. So this new service really helped people access addictions and mental health services throughout COVID. So again, the wait list reduced tremendously with the implementation of one-time therapy, and clients were really pleased, even with one session, that it helped them. So before the OAT session, 78% were worried, upset, or very worried and upset. And after that one session, 18% were worried or very worried. So it dramatically, you know, or dramatically, it really helped them with the needs of that day, I should say. Maybe next slide. So again, 92% were really satisfied with that one-at-a-time therapy. Some of them are coming. So it's again trusting in the system that they can come. The door is open to them at any time. And that's really great. I always remember when we started this journey, it's not necessarily trusting in the therapist, it's really trusting in the system. And that is, that's what we're hoping to accomplish with this. Maybe next slide. Again, sorry, I didn't realize that it was step by step. So again, we are starting the journey of the step care model. Lots of engagement sessions are planned for 2024. Just the framework itself, you know, what it would look like, the co-design of the model, it has started. And again, we're just at the beginning of this journey in New Brunswick. So maybe next slide. Lessons learned mostly with one-at-a-time therapy. So again, you know, yes, one-at-a-time therapy is fantastic, but a robust continuum of low to high intensity care services are required. It does not meet the need of everybody, but it certainly is extremely helpful. So designing, we're really looking forward to mapping out our step care model, and hearing what Danielle was saying as well. You know, this is not a cookie cutter type of step care, is not a one size fits all. There are a certain population that will need to develop their own continuum of care, perhaps. And we're starting to hear that in our province. So looking forward to those consultations as well. Again, very positive, but having a clear vision and engaged leadership, effective partnership, strong and motivated implementation team, a good project plan, and early adopters and success stories are really important to share. And again, you know, same thing as Newfoundland just mentioned, we are not accustomed to sharing good news stories, right? And I think it's pivotal. I think it's really important to change stigma towards mental health and addiction services so that people come. We have a lot of work to do in that area as well. So we need to start communicating that on our end as well. Next slide. I think I'll stop at that. So again, it's transforming systems. It takes a long time. When we start this journey, it's really overwhelming. It seems overwhelming because we are changing, the system altogether. Operational guidelines need to change. Everything is changing because of this. So it's a multi-year thing. One thing is we should have involved step care in the co-design model of from the beginning, because we launched, we did a whole lot of things, but I think we would have saved a lot of time and effort if maybe we would have consulted a little bit more based on Step Care Solutions experience with other provinces. But again, lots of patience and lots of engagement, I think, from frontline staff and directors, and is really key, because it's a long journey, I think, and multi-year facets. So, and again, we're just starting our journey and are looking forward to seeing or reaping the benefits of this. So thank you.
Thank you, Deborah. That was really informative and really helpful. And I know you've already achieved so much, and it sounds like you've got some really good learnings and next steps. So I'm excited to see the journey and see how everything turns out. And thank you for sharing. I'm already seeing a lot of the themes coming up. So like communication, engagement, continuous improvement. So that's really good to see too. And I'm hoping we'll have a really good discussion after. So next I'll pass it on to representing Nova Scotia. So our collaborative member Theo couldn't join us today, but I'm really happy, Shailene, that you can speak to us. You'll be giving us an example of a stepped care model, a service that's in a stepped care model. So I'll hand it over to you, Shailene, and hopefully you don't have too much wind. If not, we have your presentation.
I know, I'm hearing it. I'm hearing the background. And Danielle, do you have you have my, oh no. Okay, it looks like we're getting some formatting challenges here. So let's see how this plays out. Beautiful. Okay, so hey everyone, my name is Shailene Jones, and I'm the Executive Director with Eating Disorders Nova Scotia, which is a Nova Scotia-based nonprofit group that works to support folks impacted by eating disorders. So I'll speak about kind of the problem and the solution. And this whole afternoon has been like such a treat and joy for me. I'm such a huge fan of the step care model. So having a chance to listen to everyone talk about the model and how amazing it is has been a lovely way to spend my afternoon. So thank you for that. So the situation that we're facing, our problem statement, and this goes for the entire country of Canada. The challenges are not specific to my neck of the woods, but eating disorders are incredibly common, very costly, really deadly illness. They're complex, they're serious. They impact about 1 in 12 people, and they have the highest fatality rate of any mental illness. So not treating folks is kind of not an option. Many folks do not seek help. Many folks are unable to receive help. And options for care in Canada can be very challenging. Some provinces do not have specialized eating disorders programs, or there may be very long wait lists to access the programs we have. So the same kind of challenges we face across the board with all this stuff, right? Where we have a system designed for this type of treatment and people's needs are like this. And compounded by this is, again, the shame and stigma where folks who experience an eating disorder may feel like they're not ill enough to seek help, they don't deserve help, they should be able to figure this out on their own, or they just don't deserve care. So this is kind of like the landscape in which we entered. Next slide, please. Oh, I feel like Vanna, or like more like Pat Sajak, okay. So back 100 years ago, right before the pandemic, we met with our partners, Body Brave, which is our sister charity based out of Hamilton. And we were both kind of frustrated with trying to like create, immeasurable change within the systems. And we thought, what if we could just design a system that put the person in the center of everything and then built out from there? So really honoring the user experience and the client journey. And so over the next couple of years, we have been working tirelessly to build a different way that people who are impacted by any type of an eating disorder may be able to receive the right type of care at the right time in the right place, etc. So this is kind of our model. Oh gosh, it looks so similar to the step care model, including colors. So we've created a program called Body Peace Canada. And this is the program that's virtual. It's available to anyone from coast to coast to coast in Canada, anyone 14 plus, and it really mirrors the step care approach. So it's like baked into our core values. So we believe that everyone should be able to have access to the resources they need with limited barriers in place. So diagnosis, referral, not required. All of our peer support programs and self-directed programs are free of charge. And we get to the far end and we have individual services from clinicians. Those are on a kind of a pay what you can sliding scale with heavy subsidies that are available. And so this is kind of the model that we have. We go all the way up to inpatient care, day treatment specialist, family doctor. So that whole process from the beginning to the end. Next slide, please. Okay, so folks, if you take your phone and you hold it up with the camera, and you can click on that picture and it will take you to the Body Peace website. And when you get the slide deck and you have, spare time to review slide decks, there are a whole bunch of live links throughout the document. So you can learn more about everything I'm talking about here today, in your many hours of leisure time. So one of our challenges, of course, we talked about the communication piece, and you can build a Cadillac, but if it's in your garage unless you tell people about it. So we're working really hard to ensure that Canadians and service providers and clinicians and other folks are aware that the service exists and who it's for. Next slide, please. Okay. So the Body Peace platform or program, it combines a single registration with multiple program offerings. So the same thing, we don't have to tell your story again and again. We don't want folks to have to complete multiple surveys and register again and again. So it's one registration. And then from there, they can access all of the services that are available. And this includes a self-assessment. And folks can use this tool to take back to their family doctor to advocate for the right level of care that they might need. It also helps us kind of come up with our curated list of resources. We heard from folks that having too many options was problematic, and that it helped having a more curated list. Here's your top 5 next steps. So it's not completely overwhelming. So once folks have registered for the program, they receive their curated action plan, and it's based on a whole bunch of different factors like where they are, how old they are, what the level of severity is, and then they get offered their action plan. And it includes the curated readings, videos, reflections they can do themselves, pre-recorded workshops, live workshops, recovery sessions, a lot of education, self-guided support, as well as the full suite of peer support services that we've been offering here in Nova Scotia for 20 years. So we have drop-in groups, we've got specialized groups for young adults, for women 40 plus, for LGBTQ plus folks, for trans folks, as well as individual mentoring. We also have kind of a help desk within the platform. And this is powered by peer supporters who are trained to assist with systems navigation. So they do all that magic of peer support, like the validation, the encouragement, as well as helping them access the right level of care elsewhere, helping them access things within the program as well. So they're kind of like the magic of the program. Next slide. Okay, so we've had some pretty good outcomes from the program. We've married the program from Body Brave, which is the recovery support program, with our peer support program to make one mega program. And their program's been extremely well evaluated. Next slide. In fact, they just were published in the British Medical Journal about the impact of their recovery support program, which is all the self-directed, self-paced things. So seeing some really fantastic outcomes here from participants just feeling supported, felt like recovery is possible, felt more hopeful, etc. So we're so honored to work with this partner. And when you get the slide deck later, click on the picture and it takes you to the journal article. Okay, next slide. Okay. And then the program outcomes for the peer support programs that we've been leading the way on. Again, fairly consistently powerful outcomes. So 80 plus participants, up to 99% of participants feeling more hopeful, less isolated, more alone, listened to, and that they're better able to cope. So for all of our peer support programs, we're not measuring eating disorder symptomology, but we're looking at motivation, hopefulness, readiness for change, knowing that these types of programs can kind of help them get ready if they need to do more intensive work. You've got some quotes here, or some numbers here about the peer support program, the one-on-one mentoring piece as well. All right, next slide. Okay. Oh, rapid access to the right service, right? I feel like I'm banging the drum we're all talking about today. So creating a system where people had almost immediate access was really important to us, and looking at how do we close those timelines from when they register to when they get their action plan, like how do we keep that all really tight in a way that's meaningful for people, and what are people's comfort levels with wait times, and what does that look like? So right away, they get all the self-directed pieces immediately. They get their self-assessment, they get their action plan right away. Within a week, usually less, they're able to access a drop-in peer support group. Depending on what day of the week they register, it could be the same day or up to 7 days later, as well as the live workshops and information sessions. In Nova Scotia, I'm extremely proud to say that they can see a clinician within 1 week of registering for that. Sometimes we've had as quick as 48-hour turnaround time. So it's keeping the supply and demand perfectly matched. Within a month, they're able to be matched with their peer mentor. We spend a lot of time matching them, so the matches take. And then in Ontario, it takes about 3 weeks on average to get matched with the clinician. Similar to what y'all are finding, most of folks who are registering for the program, who are program users, only want the self-directed services. They're like, I want to learn about it. I want to do my reflections. That's where I'm at, and that's good. And only about 30% of folks actually required or even wanted the clinical level of care. So we're able to support 70% of clients without actually providing that individual support level of support. Next slide. So where we're at now that we've been working in this program for the past year and a bit, is we're doing iterations of it. So we have kind of our base model. And so now we're working with different groups to customize the action plans, to look at what data reporting they might want. So we're working with Bridgepoint Center, another group out of Saskatchewan, integrated youth service hubs in collaboration with our partners there, to look at how do we fit this model to support clients in different communities in different contexts. So we're looking to continue to grow the program in that way, and really connecting the services with the people who need it. Next slide. Oh, and there's my information right there. And I have one more slide from here. Okay, excellent. Bonus content. So when you get the slide deck after the session, if you scroll through, there's a bunch of bonus content, different downloads, our whole marketing communications campaign to really drive traffic to the website and engage the users and encourage folks to sign up. We also have an information session every month. Next one is tomorrow. The next one after that is in January. So if you want to find out more, you can email me or call me. I love talking about this so much. So anyways, that's it for me, folks. Thank you so much for the time and the agenda today.
Thank you so much, Shailene, and thanks for sharing that bonus content. Like, this is such a valuable resource and such valuable resources and service. And I love that you're, promoting and championing like peer support, getting people care. I love that you're sharing your promotion materials. Like, we've just been hearing how important communication and engagement are. So I think these are all really, really helpful. So Lita, I'll get you to skip through the next couple of slides just to show people a preview. But yeah, I think this is so helpful, Shailene, and it's good that it's coming out of Nova Scotia, but now has, expanded, and we've done such great work with Nova Scotia Health. So there's, you know, a lot of like this really fits in well with the really providing a full continuum of care. I know they've put in so much work into their e-mental health offerings, and it's just so great that this is available online.
Awesome. And we're looking forward to working with other provinces as well. So if folks want to chat more about how this might work for your province and your pathways, I'd love to chat more.
Sounds great. Okay, and then next I will be passing it on to Health PEI. So I will pass it on to Abby. So over to you, Abby.
Thanks, Danielle. Hi, everyone. My name is Abby Fredericks, and I am the Step Care Coordinator working with mental health and addictions at Health PEI, which is the health authority on Prince Edward Island. So I'll be providing a bit of an update on the work that we've been doing and some of the lessons learned so far. So next slide. Awesome. So similar to New Brunswick, we also started with looking at implementation of one at a time here on PEI, particularly looking at what are different ways that we can improve access, looking at sort of that rapid access, same day principle of Step Care 2.0. So one at a time really fit with the need at the time. So these are sort of the three components of the implementation specifically around OAT. So we started really with training, so equipping our providers with information on step care, but also on the one at a time approach, having some live dedicated sessions. And also we recently have a provincial community of practice in place to continue sort of that ongoing learning. We then transitioned into a bit of a soft launch approach. So really providing space for clinicians to trial the approach, see where it works for them, where it works for their clients, and really sort of build that confidence in the approach itself. We also changed our documentation to align with those one at a time approach, and also with more of a strengths-based approach as well. So in collaboration with our providers and our patient advisory group, we really flipped that documentation around and standardized what was being used across our community sites. And now we're sort of moving into more of the further integration process. So looking at how do we continue to build out use of this approach? How do we really continue to align it with step care principles? And part of that has also been increasing our communication to the public, but also specifically to referral sources. I know some other jurisdictions mentioned the importance of communication. So we are finding that right now that we really are looking at sort of some continued dedicated communication to specifically referral sources. And an example of that, we've been working with MHCC to produce sort of a bit of a postcard to send out to different audiences around the one at a time service and what people can expect. So that's kind of a big chunk of the work that's been happening over, I guess it's been about 1.5 years now. And now we're sort of moving into, I guess, a bit of the second phase of our step care implementation. So next slide, please. Perfect. So this sort of second phase, which has really been happening concurrently with our one at a time implementation, is really looking at the model itself and developing the model for PEI. So this started with a specific co-design process. So we started this off in August with support from Step Care Solutions and MHCC. We hosted a number of community engagement sessions with our Health PEI staff, with a variety of different community partners on PEI, and also people with lived and living experience. And the purpose of these sessions was really to have conversations about what is working really well on PEI, where are there opportunities to leverage partnerships, what do people want to see more of, and then where are their challenges and where are their barriers to service. So really getting at the core of why we are looking at implementing Step Care 2.0 on PEI, but really looking at that community perspective and what do people in the community really want to see and what would be most helpful. So that was a really interesting process, and I think really valuable to us on PEI. And I would encourage other jurisdictions, if you have the opportunity to have these types of engagements. It was really helpful just to even have that initial discussion around what could this look like for PEI and what would be most helpful for people. I think at a system level, we had sort of an understanding, but I think it was so important that we captured that community perspective as well. So that was sort of a really key part of that initial process. And then we compiled that information into a bit of a report to share back with participants, but also to have for ourselves as a project team to help guide the work moving forward. Was a lot of valuable information collected. So that was also a unique process in and of itself. And next slide, please. So from there, we've been using sort of the information compiled from those co-design sessions and some ongoing engagements, as well as sort of plugging our services along that Step Care 2.0 9-step planning framework. And from there, right now, we're actually in the phase of building the draft visual. So we're actually looking forward to hopefully having that draft by the end of this week, which is really exciting for us on PEI. And the next phase will be starting in the new year is having some more dedicated engagement with our community partners, with our staff, and with people with lived and living experience to further consult on the model design itself, what resonates with people, how would we like to communicate this moving forward. But really excited to have sort of that starting point of a draft model to work with, and looking forward to continuing to build that out with our community as well. So that will also include a bit of a communications plan around how are we communicating this model as a tool moving forward, and also looking at sort of that ongoing sustainability, which I understand is also a key component that other jurisdictions have been discussing as well. So looking forward to that piece. Next slide, please. So a bit of lessons learned thus far. We're still, I think, in the early phases that we can't really speak fully to the impacts or lessons learned of our implementation, but definitely even at this moment, there are definitely a lot of lessons learned that we can share now. So I would say benefits of the approach that we've seen thus far really speaks to sort of the model recognizing a variety of resources, both formal and informal, and really validating the importance of having that range of services that are offered both from us at Health PEI, but also our community partners, and also some of those maybe more informal services, and recognizing those as an important piece has been really beneficial for all of us. Also, that focus on autonomy and sort of that person-centric focus, having that at the forefront is also very beneficial to have as we move forward. So that's been really sort of bit of a guiding light for us as well. And also the idea of prioritizing timely care by ensuring that people are accessing the level of care they need when they need it. So helping people access a range of supports and helping to ensure that people aren't bottlenecked into one service that maybe doesn't fit the needs. So really shifting that idea that I think Alexia was talking about earlier about sort of shifting some of those perspectives around traditional care. So that's been sort of the benefits, some of the impacts on our work. I would say increasing the awareness of what's available. In our co-design sessions, we did a bit of an exercise of going around and thinking about what existed along sort of that continuum of low intensity to higher intensity services, and the just amount of resources that people were sharing, and lots of resources that people maybe weren't aware of before. So that in and of itself has been very beneficial just to start the conversation about the strengths and supports that really do exist on the island. So helping people to see that has been very beneficial. I would say it has also provided us with sort of a guide or just a consistent approach to how we're communicating our services, how we're communicating our access points, sort of moving towards that consistency, and that no matter where you go, the information that you're receiving about the system is the same and that it's accurate and consistent. So that's something we continue to work towards. And also really that Step Care has supported from that system level, planning and prioritizing our work, which has also been very helpful, and looking forward to continuing on that regard. And then next slide, please. And sort of to end it off, a bit of our current maybe not necessarily challenges, but really some questions that we continue to work through and that we're looking forward to working through in the new year is really looking at how do we further integrate the Step Care 2.0 principles or the core components into our services. So things like measurement-based care, same-day access, how do we continue to look at rolling those out in our province? Also looking at what does implementation of Step Care 2.0 look like at the person level. So a lot of what I've spoke to has been around sort of the system planning, but we're really looking forward to further understanding and further engaging with our community partners and people with lived and living experience to understand what does this look like for people who are accessing services, and what do people really want to see, and what do people need. So I think that's something that the co-design sessions was definitely a good start to that, but looking forward to continuing that work. And then also implementation impacts in other areas. So starting to think about how does this impact, or how does this maybe align with some of our other communications materials, our communications approaches, our navigational resources, things like our website. So starting to think at what are those maybe more farther reaching impacts of implementation. But so far, so good. And things like this collaborative are really helpful. And I think to hear from other jurisdictions and to share some of these learnings, we really appreciate it. And I think, yeah, it's great to have these channels opened. And that's it for me.
Thank you so much, Abby. That was really helpful and really good learning so far. I really appreciate what you've shared. And I'm really interested in, and I know Steps Care Solutions has a lot of good resources for this too, about really how can you continue to integrate the principles into your service delivery. So I think that's really helpful, and we can help with communication. So I'm really, things are going so well, and I'm just really curious to see next steps too. And then finally, last but not least, we have Northwest Territories that will be sharing some of their journey. I also just wanted to acknowledge that we're going slightly over time, but these presentations I think are so helpful and so important. So we'll just cut the break a little bit shorter, and then we'll go into discussion after that. But definitely, last but not least, I'll pass it over to Carly and Sandy, and I see Tracy's also here as well. So over to you.
We can be super quick too. I think we echo probably what everybody has said so far. So hi everyone, I'm Carly Straker. I'm the manager of system quality and integration with mental wellness and addictions recovery in the NWT. And Sandy, I don't see you here.
Yeah, I'm here. Yeah, hi, I'm Sandy Little. I'm the territorial manager of mental health and community wellness. So I'm with the Northwest Territories Health and Social Service Authority. We work in partnership with Carly and her team at the department. We have 7 health and social services authorities across a really vast, isolated part of Canada. So Step Care really is important for us. Yeah, next slide, please. We structured our slides around the questions, the prompt questions. So we wanted to start with initial successes here. Carly, do you want to start? Because this was your original vision. Yeah.
Yeah. So probably one of the biggest things that we saw when we started implementing was really huge reduced wait time. So it's around 79% reduction at that time. You can kind of visit our final report if you're interested. I know Danielle made reference to those on the Commission's website. We were really excited about that piece, obviously, though, because our main goal was to really increase access and options for people. So you'll see that there, expanded choice, access point options, and we removed barriers. One of the very first things we did when we implemented Step Care 2.0 was, and I think Danielle, you mentioned this as well, or Anne-Marie, but we took away the precursors to care. So we used to have a whole intake process that was pretty lengthy. And then the first session, people generally did a biopsychosocial assessment, and that was a part of the standards of our program. So we removed all of that, not to say you can't do assessments, but it's care first, assessment later, which is one of those kind of core components of Step Care 2.0. And so instead of people kind of having 3 touch points with our system before they even got help, now the first thing they get when they reach out for help is help. We expanded choice through e-mental health initiatives, through different ways of entering into our counseling program. So you can call in, you can drop in, you can have a same day appointment, you can have a scheduled appointment. And so, yeah, we just really expanded access points and options. We can go to the next slide. Thanks.
In terms of practical actions, maybe I'll start because this is what we've been doing with our staff on the ground. As Carly said, removing the barriers, just skipping right over the intake, we said you can have an assessment if that comes up in your process. And we've changed the standards and the standard operating procedures to reflect that. So removing the biopsychosocial assessment has been huge, and that has helped us to eliminate that, along with one at a time approach, has helped us to eliminate the wait list. So those are two huge things. Maybe next slide, we'll start to talk about some of the benefits. Yeah. I'll start and I'll let Carla jump in. So this has had a huge impact for us to shift people coming in with kind of Western traditional training that says, I know what's best, I'm going to ask the questions, even to the point where some of our folks in training have said, but I know this person really didn't need to talk about this. They really needed to talk about something else. And that's been, and Ree's laughing because she remembers that. So really addressing our privilege, much less of a top-down approach, an increased ability to trust people with lived and living expertise to say, what's important to you? What do you want to talk about right now? What do you think you're ready for? And putting the person at the center. We always talk about person-centeredness, but our system was not at all structured in that way. It wasn't structured to put the person first. It was like, well, let us ask our questions first. Hold that thought. We'll get back to that. We'll tell you what you think you should do, whether you think that fits or not.
Yeah, totally. And I can speak to the mental wellness addictions recovery advisory group. So this is something we implemented really early on too, as a part of Step Care 2.0 implementation. And so it's a group of people with lived and living expertise from across the Northwest Territory, so in different regions of our territory, who work with us and right from the onset of program planning or planning for communications materials or initiatives, really anything and everything that comes through our unit. And then we also extend that out to other people. So I know Sandy's team uses them as well. And we really just engage with them ongoing. And this is something completely new. We didn't have this in our system before. And so, yeah, we love this group. We're really thrilled. And we feel like our system is such a better system because of that, because people are engaged right from the onset versus kind of an afterthought or after the fact. And so we use this ongoing throughout any program planning. You can go to the next slide.
Top 3 lessons learned. You'll see this reflected in many of the presentations. So change management and communication. Change management was so critical and it had to be ongoing. And Carly has a famous thought that you have to say things like probably 20 times before people sometimes incorporate it and hear it. So we've worked really hard with our staff. What we realized was also the people who have expectations of what mental wellness and addictions recovery and substance use health should look like. If you've got psychiatrists and physicians in primary care saying this person is in deep trauma, they need therapy for the rest of their lives, and they need to see a person in an office once a week. We have to do a lot of training and education with those folks as well. That's been a big challenge. Having champions at all levels, identifying people who are really keen about this. And it started with Carly and the department, and then we've worked our way throughout the system to say, who are the people with lived and living expertise champions? Who are the frontline staff champions? Who are the regional champions? And the service users as well. Building capacity. We've had, like many people have said, a multi-pronged training approach. So starting with some conferences, with some of the asynchronous online training, lots of follow-up with Step Care solutions and some solution finding sessions. We call them, instead of problem solving, it was more like finding solutions, and just reframing things that way. Helping people shift to a more recovery-oriented approach has been one of the biggest challenges. And I think that's going to be, yeah, that's the next slide, actually. Unless, Carly, if you want to say anything else here, we can bring it to challenges. Yeah.
Oh, go ahead. Yeah, you're right. Do you want me to speak to this one?
Maybe I'll speak to the first one and
yeah.
you can speak to the second one. Yeah. So this was where we found the most pushback from service providers as well as service users, people coming in and saying, but depending on the level of complexity or the level of severity, people had an idea that they should be somewhere further along the continuum of services. We have some great examples of people on psychiatry, inpatient psychiatry, our highest level of service, also using e-mental health. And we've got some really great champions in the hospital saying, people don't have to, e-mental health doesn't have to be, or self-help and peer support does not have to live only with the people who are fairly well and fairly functioning in the community. Are people who are struggling the most are also using that as well. So shifting that narrative has been really, really challenging, and looking, it's been also super rewarding, looking at who else is helping in people's lives, knowledge keepers, elders, on the land services, things like that. And I'll let Carly speak about the final point here.
Yeah, and we had been talking, Sandy and I, just before this presentation, wishing that we had added our visual, our Step Care 2.0 visual, because we created it in a little bit of a more circular, well, it's a circle, versus kind of that stepped staircase, partly because it just seemed to fit more with our population and our communities up here, but also because of what Sandy just said. And we found that wasn't being captured when people were looking at kind of that stepped approach in our territory. So with a circle, people kind of seem to understand a little bit more that they could be kind of in this circle over here with peer support, but they could also be here having, you know, counseling, scheduled counseling, and they could also be doing e-mental health. And it wasn't just one thing and then the next thing and then the next thing. So yeah, kind of just to build on what Sandy said, and then that shift from the rigid Western counseling model to recovery orientation. I think we've spoken to this in a few different ways, but really moving away from I'm going to tell you what you need to talk about, or I'm going to tell you how many times you need to come and talk to me, or this is exactly what it's going to look like. We've just kind of moved that wide open and really become more of a person and family centric system where we're kind of, it is co-led, and it's not just about sort of a person, you know, from this place of knowing. We recognize that the people come in are holders of wisdom, and they know their own lives, and they're the experts of their own lives. And we're being more responsive to that. So, and the system is supporting that now, whereas before it wasn't. When we were doing these 60-minute sessions, and that's all we offered. So I think we can go to the next slide.
All these outcomes are contained in our final report, which is on the Mental Health Commission website. It's also on our NWT websites. We can share those links with you. So one of our hugest things, this was the thing we were most proud about and had struggled the most prior to implementing Step Care, was wait lists of 6 weeks to 6 months for people. And any of their service would be like, get an assessment and be told to go back on the wait list. So 79% reduction in wait times, that was our hugest outcome, but also really high satisfaction rates. The numbers are there. I'll let you read them. I won't walk through all of that. And probably the next slide. We did a little bit of thinking about our final kind of final lessons. If we had to distill this into something, or if there was a little summing up that we would say. Carly, do you want to start?
Yeah, we'll just be through it. I think a big part of it was to have vision, like that big system thinking, and that can be really challenging. But to think where we want to go and not get too stuck in you know, these smaller pieces, but seeing how they all work together. And I think what really landed for us, and it's there, the third bullet, was the fail forward concept. And not only, you know, having that in our system and in our sessions with people who come in for counseling, but to embody that at our work as well, and in our work in implementing Step Care 2.0. And then we talk a lot about grit. It takes grit to be able to you know, do huge system change and system transformation of this level. It's big. It was, for us, it was huge. Do you want to say anything further on that, Sandy?
No, I think just the pushback, the fear, and the fear came from lots of folks, but it started at the level of our service providers. We've heard it also from service users who said, but does this mean I won't get what I need? This, you know, therapy for life kind of option. And we've also heard it from communities who, when we started to talk about where Step 7 fits, where individual counseling fits in the whole model, their first impression was, are you saying that you're now downloading and offloading all of these services onto us, and you're just pushing this onto and asking us to do more with no resources? We said, actually, no, it's the exact opposite. Now you have so many more choices and so much more connection. So even e-mental health, looking at the presentation we just had about eating disorders, and thinking, wow, so our folks in the NWT can connect to that. They don't have to live in a big city center, but they can connect to really important services. And we came up with a couple of words here. We were thinking about what our if we had to come up with one word to describe Step Care 2.0, for me, it was, I said person-centered, but also anti-pathway. We work in a system that loves pathways. We work with lots of medical folks and people who always want to say, if you're here or you're this, I have to go there. And Step Care was so not a pathway. It was so many options for people that it was really joyful to say, what is going to work for this person as opposed to fitting the person into the pathway. And Carly, you had a couple of words you had come up with.
Yeah, that one's huge for us for sure. And I think Byron, you talked about it too, where there's not one way. I think it was probably a lot of us have spoken about it, but there's not one way for every person. Everybody's going to have a different approach, and something that works for one won't work for another. And so we've really tried to integrate that into our work. One word I use, and I recognize everyone's words will be different, but is intuitive. Step Care 2.0 just feels really intuitive to me, especially the whole concept of help first, assess later, and just there's no precursors to care. When someone comes in, you're available and you're there to help that person, and they're not kind of being pushed off to the side for sometimes a really large amount of time. There were some people that were actually pushed on the wait list that it was a year or so even, and so they don't even remember why they were coming, or things have gotten way worse, or so I think for me, it's just intuitive. When people come for help, we're available to help, and we've set our system up to be able to do that now. There's still so much work to do, but we're on our way there. So yeah, and I think that's it, right? No more slides. Lots to say about it, but we'd love to have more conversations with people. And like others have said, I think this collaborative has been a huge support for us while we're working towards all these different pieces.
Thank you so much, Carly and Sandy. Just really wonderful work. I know one of the keywords you've said as well is just, this is just a really human approach. So just really wonderful work. And we've put the links in the chat as well, but I see that you have it here. So that brings us to the end of the presentation from our wonderful partners.